Welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Dawn Liz Powell, Medical Editor at MIMS Learning. Here with me in the studio today are my colleagues.
Hi, I'm Pat Anderson.
And I'm Sangeeta Krishnan.
Today we will be talking about chronic obstructive pulmonary disease, or COPD. As you very probably know, given its prevalence in primary care, it is a common, debilitating, life-threatening progressive condition. Recognising the heterogeneous nature of COPD has become increasingly important. So much so that the Global Initiative for Chronic Obstructive Lung Disease, or GOLD, now includes heterogeneity in its definition of COPD. Prior to 2023, GOLD called COPD a common, preventable and treatable disease that is characterised by persistent respiratory symptoms and airflow limitation that is because of airway and or alveoli abnormalities, usually caused by significant exposures to noxious gases, particles or gases. But since 2023, GOLD defines COPD as a heterogeneous lung condition that is characterised by chronic respiratory symptoms because of abnormalities that cause persistent, often progressive airflow obstruction.
That's interesting that they've refined their definition and there's now an emphasis on COPD being heterogeneous. What this term means in the context of COPD is that the disease consists of a number of pathological processes whose effects are modified by the susceptibility of the person affected. So, for example, some patients have a lot of cough and sputum, suggestive of chronic inflammatory processes, while others may have dyspnea caused by hyperinflation of the lungs. But taking a step back for a minute, can you just say what GOLD is and what its role is in COPD?
Okay, so GOLD is a global organisation that each year publishes a report that provides, or at least seeks to, state-of-the-art recommendations on the diagnosis and management of COPD. The report is written by leaders in the field, both in research and in clinical practice, and is based on the latest and most robust scientific data. From what I can understand, many healthcare professionals in the respiratory field see the GOLD report, and pun very much intended, as the gold standard source of information on COPD. However, of course, when it comes to diagnosing and managing COPD in England, the NICE guidelines should be followed first and foremost.
Right, so that's what COPD and GOLD are. But shall we talk about prevalence for a minute? Dawn, you mentioned that COPD is a common presentation in primary care, but I've come across some statistics showing just how common it is. Data from the Quality and Outcomes Framework show that overall, approximately 1.17 million people in England have COPD, which is around 1.9% of the population. COPD is associated with high mortality rates. In 2021, there were more than 21,000 deaths from COPD in England, which equates to a rate of around 40 deaths per 100,000. Additionally, COPD represents a health inequality. Prevalence is higher in the north of England and in deprived areas. In fact, in the most deprived 10% of areas in England, prevalence of COPD is estimated to be almost double that of the least deprived 10% of areas.
Yeah, and also a quite astounding statistic is that according to NICE, there may be up to 2 million cases of COPD still undiagnosed in the UK. A 40% increase in COPD prevalence is projected by 2030, posing an annual cost of $2.5 billion to the NHS, of which most relates to the hospital management of COPD exacerbations. So I understand that smoking is a key cause of COPD?
Yeah, so actually COPD is predominantly caused by smoking and is therefore largely preventable. Our recently updated module on COPD pathology and diagnosis says that smoking is associated with airway and to some extent pulmonary inflammation. However, it states that the exact relationship between smoking and COPD is not clear-cut. While smoking cessation slows FEV1 decline and improves symptoms, it seems to have little effect on airway inflammation. But obviously, whatever the exact nature of the relationship between COPD and smoking, encouraging people with COPD to stop smoking is vitally important.
Yeah, and the module lists several other risk factors for COPD, such as age, occupation, and poor nutritional status. It also mentions that alpha-1 antitrypsin deficiency is a risk factor for COPD. The NICE COPD guidelines state that serum alpha 1 antitrypsin should be used to assess for deficiency in people with early onset COPD. Early onset is when it occurs below 40 years of age, minimal smoking history, or a family history of the condition. Patients with this deficiency should be offered a referral to a specialist center to discuss how to manage their condition. Alpha 1 antitrypsin replacement therapy is not recommended. According to a MIMS Learning module on COPD management, which accompanies the pathology module, the main reason for testing for this deficiency in people with COPD is to help identify blood relatives who might also have the condition so that they can be counseled against smoking or advised to stop smoking if they do smoke, given that smoking is going to further increase their risk of COPD.
Okay, so we have a rough idea of who's at risk of COPD, but what are the signs and symptoms? As you might expect from a condition that affects the lungs, there are some key respiratory symptoms. There's shortness of breath on exertion with progressive reduction in exercise capacity. And in fact, according to the GOLD guidelines, breathlessness is the cardinal symptom of COPD. There's also a cough, which is usually productive. I think we've all heard a smoker's cough. But as already mentioned, because COPD is heterogeneous, the main presenting symptom may not necessarily be productive cough. It depends on how the disease manifests in your patient. Other symptoms can include wheeze and tightness in the chest.
Moving on now to diagnosis. According to the pathology module, there's no single diagnostic test for COPD. It states that conventionally, diagnosis is based on symptoms and clinical judgment. However, the module reports that spirometry, specifically the FEV1-FVC ratio, is the gold standard test for assessing airflow obstruction. It adds that the simpler, easier peak flow expiratory flow test also measures airflow obstruction, but is less reproducible and is less robust. The module has a lot of information on the FEV1-FVC ratio and what various readings indicate. For example, it says a post-bronchodilator FEV1-FVC ratio of less than 70% indicates significant airflow obstruction. I would recommend taking a look at the module because it has a really good table on what FEV and other measurements actually mean.
Okay, so assuming COPD is diagnosed, the next step would obviously be management. I'm sure our listeners already know this, but COPD is irreversible, so cure is not an option, at least not for the moment. Who knows what's going to happen in the future? But for now, the goals of management include improving symptoms, increasing exercise tolerance and health status, preserving lung function, and reducing mortality. And as you mentioned, Dawn, smoking cessation is very important. Helping patients stop smoking includes setting a quit date and starting nicotine replacement therapy that day, but start smoking cessation drugs, if they're being used, 1 week earlier. Patients should aim for complete abstinence rather than cutting down. However, while reducing smoking has not generally been shown to be helpful, there is evidence that reducing often precedes quitting. So it makes a lot of sense to encourage reducing in those who are not willing to quit just yet.
In terms of pharmacological management, bronchodilators are the mainstay of treatment in COPD. They increase airway diameter, acting directly or indirectly on the smooth muscle to increase FEV1 and other measures of lung function. In the COPD management module, we do have a good table on the different types of bronchodilators available. The table also has information about the role that the different types play in COPD. It also talks about dual therapy and triple therapy. Dual therapy refers to a fixed dose inhaler of either an inhaled corticosteroid and a long-acting beta agonist, or a long-acting muscarinic antagonist, or LAMA and a LABA. There's also triple therapy, which consists of an inhaled corticosteroid, a LAMA and a LABA.
And alongside drug therapy, another evidence-based option is pulmonary rehabilitation, or PR. And PR is a structured program of supervised tailored exercise, ideally with constant load or interval, as well as strength and endurance training, coupled with educational components, including smoking cessation, nutrition, and self-management advice. It improves symptoms such as breathlessness and also reduces hospital readmission. However, patients can be reluctant to participate, and this can be because of time or transport difficulties. But with integrated care now a focus of the NHS, there may be signs of beneficial change. In a recent module, Dr. Ketan Patel notes that integrated care, of which PR is a core component, can enable physiotherapy-led rehabilitation classes to be held at community gyms and centres and even in patients' homes to increase uptake.
Yes, thanks, Pat. I think we should mention we have a whole module on pulmonary rehabilitation, so do check it out as well as the one on integrated care. Another core part of management in COPD is preventing and managing exacerbations. A COPD exacerbation, according to a third module in our freshly updated COPD series, is a sustained worsening of a person's symptoms from their usual stable state, which is beyond normal day-to-day variations and is acute in onset. Commonly reported symptoms are worsening breathlessness, cough, increased sputum production, and change in sputum colour. Exacerbations can be mild, moderate, or severe. Severe exacerbations carry a high morbidity and mortality, possibly exceeding that of myocardial infarction. About 8% of people with a severe exacerbation will die during admission. Even if they do survive the initial hospitalisation, up to 25% will die during the following year, 43% will be readmitted to hospital within 90 days, and up to 71% will be readmitted within 12 months. As well as all that, about 14% are still more symptomatic at 4 weeks after the exacerbation than they were before, and at least 4% will never return to their previous baseline.
Wow, that really paints a picture about COPD exacerbations and how bad they can be. Given those stats, keeping track of a patient's exacerbations would be vitally important to prevent future ones, especially because the module says that a history of exacerbations is one of the most powerful predictors of future exacerbations. As expected, a person with a frequent exacerbation phenotype, that is, 2 or more exacerbations per year, is likely to have greater airway inflammation, poorer lung function, poorer quality of life, and a worse prognosis. Now, going back to GOLD. In a new suggested system for assessing severity, GOLD now categorizes exacerbations and symptoms separately. Anyone who's had 2 or more moderate exacerbations or 1 or more exacerbations leading to hospitalization is put into category E, irrespective of their symptoms. I think he is seen as being the most severe.
Key to managing exacerbations is identifying the cause. And according to the module on exacerbations, there can be multiple causes. These can include asthma, cardiac causes such as heart failure, gastroesophageal reflux disease, infections, bacterial or viral, and even pollution. Management will not only be dictated by the cause, but also the severity of the episode. So the COPD management module has a section on managing acute exacerbations, and that says that management can include high-dose bronchodilators, antibiotics, steroids, home oxygen, and heart failure therapy. However, oxygen should not be given to patients who have a documented hypercapnia unless its administration can be controlled and monitored. Regarding antibiotics, a Cochrane review found that antibiotics have some effect on inpatients and outpatients, but these effects are small and they are inconsistent for some outcomes, such as treatment failure, and absent for others, such as mortality. It did, though, find evidence of a strong beneficial effect with antibiotics for people with COPD in an intensive care unit. The module does have good information about choice of antibiotics, so again, I would recommend you check it out. Just to recap, the modules we are referring to are part of a 3-part series. The first one is on diagnosis and pathology, the second one is on monitoring and exacerbations, and the third is on management and comorbidities. They were originally written by Dr. Philip Ind and have been recently updated by consultant respiratory nurse Jane Scullion.
We're having a bit of a whistle-stop tour of COPD, aren't we? So far, we've talked about risk factors, diagnosis, management, and exacerbations. But there's still so much more to discuss. Dawn, you just mentioned that the module on management also talks about comorbidities, so let's take a look at the comorbidities next. Given someone with COPD is likely to be older and have risk factors like smoking history, you can well imagine that they would have other conditions as well. The module notes that patients can have cardiac conditions such as ischemic heart disease and respiratory conditions such as obstructive sleep apnea. Though it also notes that people with interstitial lung disease, another topic we have a module on by the way, can be wrongly labeled as having COPD if they present with breathlessness on exertion, particularly if they're a current or an ex-smoker. So, a low threshold for further investigation in these patients is helpful, especially if spirometry is normal or restricted.
We should also mention asthma, as a lot of overlap exists between asthma and COPD, and you can have both. Our module on pathology and diagnosis states that in COPD, unlike in asthma, the course is relentlessly progressive, and the return to pre-exacerbation baseline, even after recovery, is slow and often incomplete. The module has a very detailed table looking at the differences between COPD asthma and COPD asthma syndrome, so definitely worth having a look at that.
Another thing to mention is anxiety. According to the module on comorbidities and management, anxiety may be evident in people with frequent exacerbations or those who frequently present to hospital. Depression also may be present but less obvious. The module states that determining optimum management of these conditions in a housebound, isolated patient is core GP care. Actually, we have a whole series of modules on COPD comorbidities, which was overseen by COPD expert Dr. Richard Russell. And one of those modules is an on-demand webinar presented by GP Dr. Azhar Salim on COPD and well-being. That looks at how COPD and anxiety can interact with each other, and look how COPD patients with anxiety can be supported. We also have a module on COPD and obstructive sleep apnea, as well as COPD and lung cancer. In fact, if you look at the MIMS Learning catalogue, you will see that we have 12 modules that relate to COPD. I think that just goes to show what a huge topic this is, so do check them out.
Yeah, I think there we say ourselves, we've got quite an impressive array of modules around COPD, delivering some really good education for healthcare professionals.
True, and of course, we have an impressive array of modules on all sorts of subjects on MIMS Learning. So thanks so much for discussing this topic with me today, Pat and Sangeeta.
And before we continue, I just wanted to tell you a little bit about MIMS Learning Live North. Primary healthcare professionals will gather in person in Liverpool for MIMS Learning Live North on Wednesday, 4th December. This is the unmissable event for anyone seeking the latest clinical updates. We'll bring together the brightest minds in primary care, ready to share their knowledge and provide actionable takeaways that can transform your practice. Our live presentations, interactive Q&A sessions and networking opportunities will keep you one step ahead in your field. Whether you're looking to enhance your skills, connect with peers, or gain new perspectives on key clinical topics, MIMS Learning Live North is the place to be. By attending our event, you can unlock 6 CPD hours of learning and you'll receive your certificate of attendance within days of the event. Head to mimslearninglive.com/north to register for free. We'll see you there.
Right, time to recap. Today we have learnt that recognising the heterogeneous nature of COPD has become increasingly important. In acknowledgement of this, GOLD now includes heterogeneity in its definition of COPD. Since 2023, GOLD has defined COPD as a heterogeneous lung condition characterised by chronic respiratory symptoms due to abnormalities of the airways and/or alveoli that cause persistent, often progressive airflow obstruction. As a reminder, COPD is a progressive condition that is associated with high rates of mortality and morbidity. Preventing and managing exacerbations are also important because they too are associated with high mortality. Serum testing should be used to assess for alpha-1 and antitrypsin deficiency, which is a risk factor of COPD, in people with early onset COPD, minimal smoking history, or a family history of the condition. If the deficiency is identified, patients should be offered a referral to a specialist centre to discuss how to manage their condition. Treatment with alpha-1 antitrypsin replacement therapy is not recommended. Additionally, one reason for testing for this deficiency in people with COPD is to help identify blood relatives who might also have the condition, who can be counselled against smoking or advised to stop smoking if they do smoke, given that smoking will further increase their risk of COPD. A current barrier to pulmonary rehabilitation is distance because it is often held in acute hospitals, which can make it difficult for patients to attend. In the context of COPD, integrated care services could potentially help make pulmonary rehabilitation classes to be held at community gyms and centres as well as into patient homes, potentially increasing uptake. Thank you so much for listening. Don't forget that you can claim CPD credits for this podcast, so be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. Do tune in again next week where we'll be looking at how to support bereaved patients. We have been the MIMS Learning editorial team, and this episode was produced by Till Owen.